Então, meu nome é Sérgio Arruda, eu sou um dos coordenadores das Conferências Clínico Patológicas do Instituto Gonçalo Muniz da Fiocruz, e nós estamos dando a abertura oficial a essas conferências. Eu gostaria de ter um enorme prazer de convidar a doutora Marilda Gonçalves, diretora do Centro de Pesquisa do Instituto Gonçalo Muniz, Fiocruz Bahia, para proferir algumas palavras nesta abertura. Em seguida, eu vou chamar a palestra do Dr. Sherif Zaki, fazer uma breve introdução do currículo dele, e ele fará as conferências. E após a conferência do Dr. Zaki, nós teremos um breve período de perguntas, e às 10h30 nós abriremos para 4 salas diferentes de conferências. Portanto, vai ser um desafio grande para nós administrarmos todas as conferências. Todos os links eu já enviei, e pode haver algum erro de link. Se vocês tiverem o zap meu ou de algum dos colaboradores, nós poderemos ir corrigindo os links à medida que aparecem as dificuldades. Então, doutora Marilda.
Bom, Sérgio, bom dia a todos. Sérgio, muito obrigada, né, pela apresentação. Em primeiro lugar, eu gostaria de agradecer ao convite da comissão organizadora das Conferências Clínico Patológicas do IGM de 2020. Essas conferências que têm, na verdade, crescido bastante, né? E neste ano, ela engloba a 6ª reunião do Clube de Fígado, a 6ª reunião do Clube do Rim, e a 5ª reunião de dermatopatologia na Bahia, o 7º encontro anual do projeto Pato Spotter, né? Então, cumprimentar os seus coordenadores, o Dr. Washington Luiz Conrado dos Santos, o Dr. Luiz Antônio Rodrigues de Freitas, o Dr. Sérgio Marcos Arruda, e também o nosso palestrante, né, o Dr. Sherif Zaki. Em nome da diretoria do Instituto Gonçalo Muniz e de toda a nossa comunidade, eu cumprimento os participantes do evento e gostaria de dizer que a patologia ela sempre foi parte do nosso instituto, né? Com o apoio de seus diretores, com a participação ativa inicial do Dr. Zilton Andrade e da doutora Sônia Gomes Andrade, que iniciaram o curso de patologia, a pós-graduação em patologia, que foi implantado na Universidade Federal da Bahia em 1972. Inicialmente, nós tivemos um mestrado em patologia humana, sendo implementado o doutorado em 1989. Né? Hoje, esse curso ele está sediado no nosso instituto, em associação com a UFBA, a Escola de Patologia da Bahia, que foi liderada pelo professor Zilton Andrade, formou inúmeros patologistas, entre eles os coordenadores dessa conferência. O exemplo de ter reforçado a patologia no nosso instituto foi seguido também pelos diretores que me antecederam, né, o doutor Mittermeier Galvão dos Reis, o doutor Laim de Carvalho, o doutor Manuel Barral Neto. Lembro-me, hoje, nessa sessão científica, das aulas magistrais de doutor Zilton Andrade. Ele que sempre foi um frequentador assíduo das nossas sessões científicas do IGM, ele que nos deixou, né, esse ano, na verdade, nesse ano de 2020. Então, essa homenagem também a doutor Zilton, né, que também fez uma formação muito sólida de vários profissionais, né? Então, eu considero que o Washington, Sérgio e Luiz Freitas representam hoje a continuidade desse tão intenso trabalho iniciado pelo Dr. Zilton Andrade, né, que teve um papel importante na formação desses patologistas, voltado para a área de ensino, pesquisa, com formação de profissionais para o Sistema Único de Saúde. Então, esse trabalho que tem sido desenvolvido é um trabalho espetacular, né, que Sérgio, Washington e Freitas têm realizado. o Pato Spotter, né, as respostas nesse período de pandemia, acompanhando a patologia moderna e disseminando a sua formação. Uma vez que temos... Oi?
O Dr. Zac está esperando já.
Ah, tá certo. Uma vez que temos uma deficiência grande, né, de profissionais patologistas nessa área, né? Então, na verdade, eu quero consagrar, né, dizer que parabenizo a todos vocês. A ciência e a educação como bem público precisam desse ambiente democrático para progredir e produzir os seus benefícios. Então, parabéns, Sérgio, parabéns, Washington, muito sucesso na conferência, né? E eu realmente espero que vocês continuem progredindo, né, com esta patologia. Um abraço.
Good morning, Dr. Zac. Are you there?
Yes, I'm here. Can you hear me?
Oh, yes, perfect. Thank you for coming. Sorry for our delay, but we are getting some problems. I would like you to introduce for everybody Dr. Serif Zac. Dr. Serif Zac is Chief of the Infectious Disease Pathology Branch, Division of the High Consequence Pathogen and Pathology of the Central Disease Control of the United States. Dr. Zac is a pathologist, MD. He graduated in Alexandria Medical School in Egypt. He gets his PhD in experimental pathology in the Emory University in Atlanta, United States. Dr. Zac has a long, a lot of the publications, like as I count right, 350 scientific articles. He wrote also 41 book chapters or reviewed. He has 23 honors and awards. And his focus is infectious disease pathology. So for us from the Brazil and Instituto Oswaldo Cruz, Fiocruz, is an honor to have today Dr. Zac, and he will talk about emergent infections, critical role of pathology identification and discovery. Thank you, Dr. Zac. I really appreciate your time and your patience with us, and really in name of the organization, thank you for accepting our invitation. Thank you again. Go ahead.
Thank you so much for that very nice introduction. It's a pleasure to be with you. Obviously, I would have been preferred to be in Bahia now instead of virtually. But let me see if I can share my screen.
Sometimes taking, okay, it's coming. Okay.
So you see my PowerPoint?
Yes.
Okay. Okay. Bom dia, everybody. Prazer estar com vocês.
This is Luciana. You need to reduce the size of your PowerPoint. It's too big. We cannot see the whole PowerPoint.
That's okay.
Right, you should be seeing it.
I'm seeing the.
We only see a piece of the PowerPoint, not the whole PowerPoint.
No, for us it's okay.
It's okay for you?
That's okay. Yeah.
Okay. Well, again, good morning, everybody, and I want to talk to you today about kind of a long road of discovery of new infections and pathogens. And this is my disclaimer for the CDC that I need to present. And this is an overview of the presentation I'd like to share with you this morning. So I'd like to talk about the factors contributing to the emergence of infectious diseases, talk about numerous outbreaks of unexplained illnesses investigated by our branch, IDPB and CDC, and also colleagues across the country and across the world. Then I'll give you some summary conclusions and lessons learned, and hopefully then we'll have some time for questions. So just to time it right, it's now, it's 7:25. How long should I time the talk for at this point? Should I know I had an hour. Should I still aim for that, or is that too long with the time?
Azure is okay, 1 hour?
Yes, 50 minutes to 1 hour is okay.
50 minutes? Okay, let me try it out. 50 minutes. Okay, so this is a report that I really cherish a lot. It was published in 1992. Talks about the emerging infections, the definition that you can read here in terms of diseases that have increased or threaten to increase in the near future. They defined 6 factors for emergence of diseases. You can see them here, things like demographics, technology, travel, microbial adaptation, etc. And I'm not going to talk about all of them. I'm just going to talk about one, human demographics and behavior, and I'll do that in one slide. This is a picture that was taken a while ago, but you can, I'm sure it hasn't changed much. On the left, you can see a very populated city, Dhaka, and you can see the close proximity of people together. So obviously that's with that amount of, say, social distancing or being, will be a factor to emergence and transmission of these diseases. On the upper right, that's a scene that was taken during the SARS pandemic in 2003, and it shows a wet market, basically, where you have all species of animals, birds, cats and bats and everything mixing together. And again, with that close proximity, it alludes to mutations of the virus and and emergence as occurred with COVID and as SARS back in 2003, as is what is happening now with the COVID-19. And finally, a sub-Saharan contaminated water well. You can see how that can lead to also to emergence of diseases. Now, this report is the second report that was published in 2003 and lists about 7 more factors that the authors identified in terms of emergence diseases. And I'll let you read them for yourself. It could be climate and weather, poverty and social inequality, intent to harm or lack of political will, which we all, see, not all of these, but, again, it's how much we can invest in prevention. And then we can see it now with COVID in terms of how much the politics affect how this disease is transmitted. So again, I'm going to talk about one of them, and that's poverty and social inequality. I don't have to tell this audience about what's on the right. That's a favela, I think, outside of Rio. You can see the crowding, and on the lower left is a scene from Mumbai, where you can see the dwellings very close to the urban settings. And finally, the picture on the upper left is from before the earthquake that happened in Haiti about 9 or 10 years ago. And that was before the earthquake. And it is much, much more worse. This is a single dwelling. You can see how that, just imagine, with COVID, what the situation would be. So I like to use this quote from that issue of IOM report. And again, it emphasizes collaborations. And I want to, different collaborators, but I do want to emphasize on one is with veterinary medicine, because many of the emerging infections are veterinary in origin, and I'll show you some examples. Here are some hantaviruses and rodents, like in the US, it's Paramiscus maniculatus. I'm sure it's different in Brazil and other parts of South America. But rodents, bats are emerging in terms of their role. We've identified them with SARS. Filoviruses now are recognized to be transmitted by bats and so forth. And obviously, in the US, well, not obviously, but in the US, bat-transmitted rabies is the most common form of rabies in the US. And then birds with West Nile influenza, avian flu, and finally things like MERS, which I'll talk about shortly. So the important principle in all of these is vigilance. To have an alert physician, alert veterinarian, pathologist, research scientist, and a public health official working together as a team. Now, I just wanted to mention about, as you know, I'm a pathologist and strongly believe in the role of pathology in such cases. And pathologists are frequently, as happened with COVID, when you ever have anything big happening, whether it's Ebola or SARS or anthrax, et cetera, we're in a good situation to encounter these diseases because we do a lot of autopsies, and many of these are highly fatal. But we're not alone. It's a collaboration with EPIs, clinicians, veterinarians, and microbiologists. And I just want to emphasize that autopsy is now increasingly being viewed as an effective surveillance tool. I'll give you some examples. So I won't belabor this slide, but where we start is as any a clinician or physician, we talk, think about the clinical features of the disease and epidemiologic features. But that's very important because where it happens, when it's happening, the symptoms will dictate what we're looking for. But we depend on the histopathologic pattern. That's our first thing in our branch. We look at the pathology and kind of determine what we want to test for. And at our disposal, we have a lot of things that we can use, whether culture, serology. We don't do it in the branch, but we work with a lot of colleagues who do EM, immunohistochemistry, and molecular technologies. And EM is very important in an institution like ours because it's kind of a blind tool to look at new pathogens when you don't know what it is. So it's a very powerful tool. Now, this is a long list. I started at CDC in the late 80s, and I really kind of got in this field with onset of hantavirus back in '93, and the list goes on, Ebola, Nipah, more recently things like chikungunya, Zika, and COVID-19. So I'll try to talk about a few of these. To start off, this is back in '93. This is the four corners. So you can see that in orange with the target at the four corners area in the U.S., West U.S. And we had a lot of healthy young adults. They had an influenza-like illness with a very high mortality and massive pleural effusions. They were dying within 3 days or so. And the mortality, you can see the x-rays here. And you can see that the mortality is, was about 60% in these cases. So there was a lot of concern. What is it? We have plague here in the US, in the Southwest. We tested for plague. Influenza obviously was high on the list, but everything really was negative at that point. And there was a lot of concern, as we have now with the COVID. Nothing fit. And this is a photo from one of the clinics when I was in the Southwest that year, you say at a pension, if you have a fever, etc., stay in your car. Don't come in. We'll come to you, as happens nowadays with COVID. So this is some of the autopsies, and I won't belabor this, but I'm sorry for this gross image, but these patients had a lot of fluid on their lungs, 7 liters or so or more, and that's what the reason they were dying, because of these effusions. You can see the interstitial pneumonitis on the right with intraalveolar edema massive. So how was this detected as a hantavirus? The first link was with our colleagues here in Special Pathogens Branch. They detected antibodies against some of the known hantaviruses at the time, Hanta, Humala, and so. And, it was thought, okay, it could be hantavirus, but it was met with a lot of skepticism. And I'll show you why the skepticism. This is what we knew about, because of what we knew about hantaviruses in 1993. We knew they, first of all, the geography was wrong. This disease was in the US at the time we recognized it. Hantaviruses were known to cause hemorrhagic fever with renal syndrome. So it was a kidney disease, hemorrhagic, neither of them were it. So 3 strikes, this is not hantavirus. So how was it identified definitively as a hantavirus? It was 2 methods simultaneous. I'll show you the first one is PCR with generic primaries for hantavirus. My colleagues sequenced it, and it was a new virus, and eventually was called cynomolgus virus. But more importantly, was actually seeing the virus. We developed immunohistochemistry at the time, which we, is now used routinely, used in Brazil, across the world, and to diagnose these illnesses. So you can see here the viral antigens in the microcirculation of the lung that causes these basically punching holes in these small vessels and causing the pleural effusion. So this, as pathologists, we know when you see something, there's more belief that this is not just a PCR result or a cross-reactive serology, but when you see the pathogens at the site of disease and pathogenesis, it makes, sense that this is the cause. So very quickly and within a couple of weeks, we identified this new pathogen as a hantavirus. We knew what the rodents of hantaviruses were, so it helped to focus the search for the reservoir. It's in here in the US, it's Paramyscus maniculatus, a mouse. And so why did it emerge that year, or why did we discover it? It actually existed for a long time. We actually went to our archives and found cases happening in the 60s and 70s, but nobody knew what it was. So why did it happen there? Or why was it discovered that year? There was the climate and weather. There was heavy rains that season, abundant pinon nuts, which the mice eat, so abundant rodents. And then there was the clustering of cases. You can see, it's very difficult to diagnose a single case on its own, but easier when you see several cases. You're able to compare the pathology and compare, different tests, etc. So that's basically the emergence, and that was new at the time. It was 6 months before the virus. It's very difficult to isolate. So at the time in the 90s, that was pretty neat. This is what we knew about hantaviruses in the Americas at that time. Prospect Hill, non-pathogenic. That was the only one used. And this is about 20 years later. All these hantaviruses were discovered by, numerous colleagues, both in North America and South America. I worked with a colleague of mine, Venancio Alves, in Brazil at the time. That was my first time I visited. And again, you can see all these viruses. North American, there's no person-to-person transmission. However, with some of the Andes virus, for example, that can occur. Anyhow, I'll come back to Venancio later and talk about another disease. This was about 2 years later in Nicaragua, patients again with a severe respiratory illness. Now, this time they had pulmonary hemorrhage and hemoptysis. And you can see the chest x-rays, again, something severe lung disease. In fact, it was thought to be, as happens with things like a dengue hemorrhagic fever. So people thought it was probably dengue. And or something even like hantaviruses. So a virus was suspected. You can see here some of the autopsies we did that, the hemorrhagic lung there. And within a week, really, we identified the cause of this. And this is where I come back to Venancio and my visit to Sao Paulo in 94, 95, where he showed me some cases of leptospirosis. And, show the pulmonary hemorrhage, and that made me start thinking, well, this could be lepto. And he actually gave me a couple of slides that I didn't have any cases at the time, and we used as controls, and we developed this new test here. Within, again, a week, this immunohistochemistry, which is now routinely used in Brazil. You have a lot of experience with lepto. Here you can see the spirochetes of leptovars. We use polyclonal 16 reference antibodies that react with more than 200 different serovars. So in this case, it's mechanical damage to the big vessels here that causes the hemorrhage. And you can use a silver stain. Sometimes, though, they're very difficult to interpret, especially if the patient got antibiotics. So it may affect how easy it is. Immuno is we use it very routinely to screen. You see things like hepatocellular dissociation, non-specific. You can see here some of the spirochetes in the liver on the upper right of that Warthin starry stain, and the immunohistochemistry on the right. And interstitial nephritis. So actually nowadays when we see a combination of pulmonary hemorrhage and interstitial nephritis, the first thing we'll test for is lepto. And again, you can see it here in the kidney. Now what happened, why did it emerge that year? There were abnormal amounts of rains, and this was in Nicaragua, about 10 times more than normal in the previous years. The waters were contaminated, and we had new techniques, this immunohistochemistry here, at least in our hand. And we now know that it's very well recognized, especially in Central and South America and Caribbean, across the world. And things like in India, they had 1 year, I think in 96 or 97, an outbreak. They thought it was plague, was actually being treated as plague, but we discovered later, a year or two, when we got samples, that it was leptospirosis. And, you know, just thinking about our colleagues in the Nicaraguan population, as you know, recently, 2 different hurricanes hit within a couple of weeks, the same spot in Nicaragua. And the amount of torrential rains and flooding and the, you know, poverty, social conditions, yeah, I have no doubt that leptospirosis is going to be now very common there and a problem to contend with. This was an unexplained a few years later in Malaysia in children, age 5 months and below. They were in cardiogenic shock. Clinicians were diagnosing myocarditis. And they had hand, foot, and mouth disease, so and acute flaccid paralysis. So the first thing as clinicians, you know, okay, you know, myocarditis and Coxsackie, an enterovirus. But, you know, we looked at hearts that year, about 12 or 13 hearts, and we didn't see any myocarditis. So we were very puzzled. And you can see the intraalveolar edema here, severe. So, but fortunately, one of the cases we got that year from Nicaragua had brain. And we can see this cephalitis here, these more neutrophilic, and that's typical of enterovirus 71. So we use an enterovirus antibody, and we proved that it was actually a relatively new enterovirus at the time. And it wasn't a cardiogenic shock. It was actually initiated by a neurogenic shock, you know, because it was attacking the brain. So again, we learned a lot about it, and now this is a very common thing where, you know, we can see around the world. In fact, this was in 2012, and again, happening in the same area of the world in Cambodia, and it proved to be, again, EV71. So we learn a lot over the years, and things that we didn't know, and help our knowledge and, you know, future generations in terms of, you know, encountering some of these difficult diseases. And I'm going to go quickly over this part. This was in New York City in 1999. Patients, an astute physician realized that there were some unusual cases of encephalitis. And while that was happening, and this is why I get to the veterinary link, there were basically these crows, which you can see one of the vets doing a necropsy there on the left, and they were basically falling from the sky. But there was no connection between the veterinary medicine and the human medicine. But it was a new virus introduced into North America. It's West Nile. West Nile, from the name you can see, is from Africa. And it rapidly spread through the US, like, you know, with a non-immune population, mosquitoes, it just spread. So, and you can see the pathology here, the perivascular infiltrates in the brain, and by immunohistochemistry, we use a pan-flavi virus. So we detected the virus in the brain, and eventually it was recognized as a new virus, at least in the US, West Nile virus. Again, how did it come to the States? Probably by birds migrating from you know, through different continents and flying into the US across the northern border and spreading the disease. But it hasn't been excluded that a patient traveling with being viremic with mosquitoes on board and then spreading the disease. We don't really know the absolute answer. This was an outbreak of encephalitis in Malaysia. Again, 98 or 99, and it was thought to be Japanese encephalitis, which is really rampant or very common in that part of the world. It's a flavivirus. But flavivirus, the JE virus is transmitted by mosquitoes, which didn't make sense because it was primarily occurring in pig farmers. So why wouldn't mosquitoes discriminate against pig farmers? So it didn't make kind of the epi criteria to make sense that it's JE. Eventually, we identified it that year. Cynthia Goldsmith in my lab at the year identified, and you can see the negative stain here of a nucleocapsid of paramyxovirus. This proved to be a new virus. It was named Nipah. At the time, there was a lot of pigs. There was huge pig farms, and the pigs had a very loud cough. You can actually, when I visited the area, you can say which farms had this virus by the mile-long coughs of these pigs. So eventually, they killed more than culled more than 1.5 million pigs, and there was no evidence of person-to-person transmission. So, because of the negative stain findings, we started fixing on a similar disease that had occurred, Hendra in Australia a few years ago, another paramyxovirus, and you can see the pathology is very similar to rabies with the cytoplasmic nuclear inclusions, and it has the other feature of a paramyxo, which is multinucleated endothelial cells. And on the left, these are reagents that we had used for Hendra a couple of years ago. So this was a new virus. We learned a lot about the pathogenesis. You can see here a vasculitis on the upper left, multinucleated endothelial cells, very similar to measles in terms of these endothelial cells, attacking the vessel walls in the brain and the small vessels, and then basically getting into the brain. So what happened? Why did that disease emerge? Well, it's a long story. I'll try to make it short, but it was because of deforestation in that area, massive deforestation, and putting in pig farms. Now, what happens with deforestation? The bats that were there flew away from these forests, but they came back. They came back with a vengeance. They came back, and these are huge flying foxes. You can see here one of them, and they, go on the pig stalls, defecate and urinate into the pig feed. The pigs then get the disease, and then get these cough, respiratory illness, and transmit it to humans. So you can see here the factors, again, emerging to the emergence of disease. And and that was not the end of it. We know it was a Pteropus bat. So over the years, we followed the occurrence of this virus, and cases were discovered in Bangladesh and India. However, the epidemiology was different. In this case, it was more children. And the reason children were being affected is the fact that they climbed up these palm trees to get the sap of the palm trees to drink it. So they climb up and drink that, and through filming of these trees, it was discovered that bats would fly into and drink and pee into these the palm sap, I'm sorry, and then introduce it into the children. So again, it can change, and eventually it still hasn't been found in Madagascar, but I think it's just a matter of time. Now I'm going to switch over to another factor in terms of emergence of diseases is travel. You can see here in orange, you can see the number of days it takes to navigate the globe, years back in the late 800s. Now it's just a matter of a day or so. You can get on a plane from one place to the other in less than 24 hours, you're going to be there. So there's that huge, in terms of mixing of, we're a global village, so it's that mixture. And then there's the population growth. you know, we're now over 7 billion in the world. So you can imagine it's a much different village nowadays than what it used to be. So with that, I, you know, I worked and have, you know, several Brazilian colleagues in our department, Ruscelas Martinez, doctor, who actually helped us discover what this disease was. A quote from our director at the time, there were brain malformations, and it was never, you know, in over 50 years that another pathogen, rubella, was causing congenital viral defects, and it was mosquito-borne. And Zika virus, as you all know, it's the RNA virus, again, closely related to a flavivirus, to JE and West Nile, and transmitted by mosquitoes. Now, again, the emergence, you can see, as you can, Zika originated again in Africa, then went to the Western hemisphere, to the Polynesias. And I believe you're all familiar with athletes that came training rowers into during the Olympics in Brazil, and they had the virus, and they had their right mosquito was there, and the disease just exploded in the Americas. So Rose at that time, you know, had some cases, had just joined us, and I'll tell you, show you what we found. This is the clinical presentation. I'm sure you're all from conjunctivitis, pain, rash, and then the effect on women was the striking thing that year is on the pregnant woman, and abortions and miscarriages. But that was the main scare all over the world that year in terms of women, pregnant women getting exposed to the virus. So the outcomes of, you know, the infection, you can get microcarriage, the very specific microcephaly, arthrogryposis, ophthalmic, you know, and it happens in the first trimester. As we know, the babies are really growing fast at that time. And then, you know, late onset effects, we're suffering from that now in terms of a lot of these mental problems that occurred and are continuing in this population. This is the typical microcephaly that you see with these kids. And again, the reason why it occurs in the first trimester is the rapid growth of the different organs, the brain, et cetera. You know, you can see the CNS at the top, you know, how it just, and with rapid growth, it is a target for the viruses. So these are some of the tissues that Rose brought with her. You can see here the amount of staining in the brain in red here. This is the immunohistochemistry. You can see the different neuronal cells, glial cells, white matter. So it's just a tremendous effect, and you can see why it causes the defects. We have calcifications, as you can avoid calcifications here, which is characteristic. And again, the antigens in these dead cells, you can see them in the areas of calcifications, dead neurons. And here's on the right, you can see the typical particles of a flavivirus. Ophthalmic complications, you can see here one of the retinas from one of the patients, and you can see the massive, again, antigens in red in the retina. And again, in different stages of infection, you can see here in the lung, you can see it on the lower left in the liver, epithelium, in the middle, on the top, that's a limb, upper arm or forearm. You can see the cartilage, and why this would cause these, the arthrogryposis and these effects. This is the placenta. You can see it in the middle panel here in the villi inside. This is on the fetal side. And then on the right is on the maternal side. So that's why the virus goes from the maternal to the fetal and causes these transmissions. So a related virus in chikungunya, again, transmitted by, not related, but transmitted by the same vector. Again, you can see how this virus traveled again from Africa originally. Basically, it's a African word meaning can't bend up. These patients with chikungunya have a lot of arthritis. Again, originated in Tanzania, got its name from there, and then eventually you can see with these arrows how it spread to, again, to the Far East and to Europe, and then basically into the Caribbean, and caused this, which we at the time recognized in Puerto Rico. So these are some of the symptoms of the disease, and muscle headaches, rash. And here's some of the pathology. You can see why it causes the joint pain. Here, the virus is enveloping a nerve on the left, so you can see why the severe pain. You can see it in the skin causing the rash and joints on the right. So here's the periosteum, and you can see the virus on the upper right, and why this would be very painful. If you get your periosteum, that's a very painful site, as we all know. And the reason it causes thrombocytopenia, it attacks the megakaryocytes, as you can see on the lower right. We can see it in vessels here on the upper left. You can see the platelets staining. So that's, and in the heart. So that's the cause of thrombocytopenia. And you can see it attacks, like hantavirus, a lot of the follicular dendritic cells in the spleen on the left, and again on the right in the heart. And have some, sorry, repeated slides. Okay, so this is the last part of my talk. And I'm going to switch gears to some respiratory infections, viral. And I'm going to start by talking with influenza and the tropism of different viruses in terms of respiratory viruses. So this is influenza, all familiar with influenza, and prior to the pandemic in 2009, this is what we thought about the pathology of influenza, basically a tracheal bronchitis, you can see on the right, and an interstitial pneumonitis, not very severe lower lung disease. And this is the distribution. This is a case of flu B in the upper airways, attacking again the pneumocytes. And then the pandemic occurred in 2009 and got this, again, explosion of cases. And what we were seeing this time was very different than the seasonal influenza. With this H1N1, you can see in this markedly obese patient was one of the risk factors for this disease. You can see these hilum membranes, saying that it was really a viral pneumonia per se, not an upper airway. We also saw the same kind of staining in upper airways in mucus glands. So it was an upper, and that's why it transmits very easily. But the different thing was with H1N1, we were seeing it also in the lung, basically causing a severe viral pneumonia. You can see here the pneumocytes in the lung, just the heavy load, and here it is in the hilum membranes. Again, type 1 and type pneumocytes, everything here in red is virus. So it was a very severe viral pneumonia caused by H1N1. Now, we also saw emboli, as we're seeing now with COVID, with thrombosis and hemophagocytosis. And again, same of the risk factors that cause COVID-19 nowadays, we recognized it with influenza, H1N1, things like morbid obesity with the BMIs, more than 30, chronic vascular disease, asthma as predisposing. And again, I show these because these are basically the same factors that we talk about now with COVID. Diabetes, the old age, immunosuppression. And in that year, we looked at about 600 cases from around the world. And the point I want to emphasize by this slide is half of these cases would not have been diagnosed as influenza except by autopsies. So again, the importance of autopsies, and now things are changing with decreasing numbers, but still things like minimally invasive autopsies and needle biopsies help us still with this. So this gets us to SARS. This was in 2003, very similar to what we're seeing now. And we discovered it again here at CDC with many of my colleagues here interns, and really give credit again to the electron microscopists, both Cynthia Goldsmith and Charles Humphrey at the time, seeing this. This is a culture here, a cytopathic effect, and you can see the typical coronavirus. That was the clinching that this was a new disease. I thought was metapneumo, respiratory, flu. Nobody knew what it is until we saw it under the EM being a corona. And it started really, why did it occur that year? It was, why was it so widespread? Again, travel. This is a hotel in Hong Kong called the Metro. I think it's changed its name since then. And the first travel patient was from Guangdong, from China, as occurred this year from travelers from China. He traveled to Hong Kong. He was a physician, stayed on this 9th floor of this hotel. And this level of the hotel was a smoking level. Air was being recirculated over and over in that same level. He infected, and thereby he infected a lot of patients on the same floor. And you can see the explosion, how it went to Vietnam, Thailand, Germany, Canada, and the US. So again, travel being a factor, emergence of a virus. And why did I showed you this on the lower left, the wet markets. And it was thought to be a civet cat, again, mixing of animals that fortunately the virus adapted and mutated out of existence. But again, this points to microbial adaptation and travel. And now we know the reservoir is a bat, this horseshoe bat. This was a scene from 2013 with another coronavirus. This was Middle Eastern respiratory corona, MERS. And it was first emerged from the Arabian Peninsula, linked to camels. And then it started spreading everywhere in the Middle East and across the world. So this was back then, the number of cases, and you can see it then similar to MERS and COVID, it traveled across the world. It was linked to camels and camel urine, basically being consumed by, in the culture in the Middle East, that's supposed to be an aphrodisiac. But again, bats, camels, and you can see here how it emerged. And so this is a patient in 2014. I was asked to, there was a fear of a super spreader event. And you now know what a super spreader event is. It was a patient from the Philippines who resided in the UAE. at that time, and he died. He had a history of, he was a non-smoker, restocking ambulance, and there was an explosion of cases. And the fear was that the virus is mutating, and now we're going to have another something very similar to SARS again, the spreading of this. This was the clinical feature, and I won't go into detail except that patient developed ARDS again and died very quickly. He actually, they kept him in the morgue in a refrigerator for 2 weeks before we got there and did the autopsy. But this slide is important because they thought, okay, if this is a healthy adult and now getting the disease, then it's going to be a super spreader. But by no means, as you can see from these slides, was he healthy. He had cardiac disease, renal disease, atherosclerosis, heavy smoker, anthracosis. And so not ill. Again, pathology similar to SARS and COVID, hilum membranes, intraalveolar edema. And again, we used the antibodies that we used back with SARS to quickly see it in the pneumocytes and syncytial cells on the right. And an important point, and I'll come to it with COVID, is it attacks, again, these mucosal glands. And these are, basically loaded with virus. The virus is then moved up the cilia, and the patients basically cough the virus up, and that's why it's being transmitted by aerosols. So coronaviruses have two types: the lower pathogenic, things like 229E and NL63. These are very common all over the world and are cause a common cold. They're not from the high pathogenic, which we talked about too, the SARS and the COVID. So I'm going to get to the last part here is the COVID emergence. Again, we know how it arose in China in 2019, and we're just seeing the pandemic was in March, and we're just seeing an explosion of cases around the world. We don't know when it's going to stop, but I'll get maybe perhaps some answers and questions. I can answer some of these questions. This is the market where it arose. Again, you can see the different animals, fish, snakes, and basically, here's the current situation in the US. We've surpassed 250,000 deaths. I know, again, colleagues in Brazil are facing the same thing with a large amount of deaths. And we're now seeing the third wave, and it's just going up. I get asked a lot when it's going to, end, or when are we going to get back to normal. I'm afraid the not so good news is not soon. We're going to have to continue with the social distancing, the masks, and hopefully the vaccines are on the horizon. But the question of availability of vaccines, we have now 3 vaccines, Pfizer, the Moderna, AstraZeneca, that very promising. You've heard about the problems with cold chains and where we can use it or not use it, but it's also availability of the vaccine. And, unfortunately, again, this is the matter of dollars and, money, vaccine. Many of the large countries in the world, including the US, Canada, Britain, have cornered a lot of these vaccines. So that's, they're going to be able to get these vaccines first. But a lot of and unless we vaccinate the world, it's not going to stop. So we have to be, equitable in terms of in terms of distributing the vaccine. But hopefully, maybe by end of the year, next year, who knows? Not sure why it froze. These are some of the recommendations. Again, important thing is not to be exposed during autopsy to aerosols. And we shy away from going for the brain, although there are findings in the brain. And I just want to show you kind of a time through some of the early days of the outbreak. We had cases, again, with the link to China, thought to be COVID. This is a patient who had returned from a business trip to China and died very quickly and thought to be died of COVID. But a team, including Rose, went out to California and did the autopsy. And the death was not caused by COVID, but by a large saddle embolism. And this is another case, again, with a Chinese connection, a graduate student in New York with a lot of contacts with travelers, again, died of COVID. COVID was negative, but this was a case of influenza, H1N1. So there are many diseases that occur at the same time. And, I'll go through this part quickly. This has been published, and I'll refer you to this article. It talks about a lot of the slides I'm going to show you next. Hilum membranes, as we've seen before, type 2 pneumocyte, basically diffuse alveolar damage. See on the third panel, the large thrombus, which is very common with these disease, and again, reactive syncytial cells. Over here, again, the chronic diseases, like we've seen with MERS, the heart disease, thrombosis, anthracosis, emphysema, all underlying. So where does the virus target? As expected, similar to other coronaviruses, you can see here the ciliated epithelium on the A and B, and you can see different types of pneumocytes, and basically attacking both type 1 and type 2 by double stains. And on the lower left, you can see an in situ hybridization, basically very similar, but probably much more sensitive than IHC. So this is what the virus looks like. Actually, on the A, you can see this is from a patient. You can see actually the spikes in the tissue. That is not usual with coronaviruses that we've worked with before. Cells, there's something different about the spike protein in this virus. So very intact, and again, more to come. And you can see on the panels on the left, the virus in E, for example, in a pneumocyte, you can see the surfactant, and then here within a macrophage on F. Important, again, and this was published in Lancet, that other mimickers can confuse a lot. And unfortunately, there's a lot of articles about the virus seen in all, parts of the body. But, a lot of these are just normal parts of the organelles or tissues, things like clathrin-coated vesicle, rough ER, multivesicular bodies. But again, unfortunately, a lot of publications have actually erroneous publications, let me put it that way. And it's important to, like with flu and others, to look for other infections. Here you can see a broncho pneumonia caused by strep. There are other colon viral infections, there are fungal infections. And here's one of these cases that was actually a transplant recipient in this paper. He was in, or she were in an elderly facility, healthcare, and the explosion of cases in Washington State at the time. And you can see actually the virus outside of the lung parenchyma and the lymph node. And now we're seeing it more with outside of the lung, not just in the lung, but in different organs, of blood vessels, endothelial cells, kidney, liver, by PCR, and more importantly, by in situ hybridization. And I think this is my last slide. Again, some of the unique complications of COVID. We have diffuse endotheliitis and vasculitis, and we know now that it's because of the endothelial tropism. and endothelial damage, and whether it's linked to thrombosis or not, that's a whole other. And the hypercoagulability, again, because of the endothelial involvement and the pulmonary. And I'll conclude on this, that I've talked to you about adult patients with COVID. We still don't know a lot about pediatric COVID. It doesn't seem to have the DAD associated with adult patients, and there are a lot of Miss C and Miss A of myocarditis, and hopefully we'll learn more. So at this point, I'd like to conclude, and hopefully I've showed you how a lot of these viruses, they're well and alive, how they can emerge, importance of a multidisciplinary approach, and traditional and state-of-the-art laboratories. It's not all serology, EM, PCR, IC, in situ, et cetera, and then frontline of a pathologist, diagnosis of unexplained illnesses, recognition of emerging infectious diseases. And at CDC, it's very important because in an agent we get support because we basically help guide the epidemiologic investigations here and around the world. So at this point, I'd like to stop and thank you for your attention. And it's a pleasure to be with you virtually, and keep safe. And I'm happy to answer any questions if there are some. I'm going to stop sharing my screen.
Thank you, Dr. Zaki. It was a very beautiful conference. We are so jealous about your slides, so clear, so beautiful slides, and very wide talk. There are many questions, but more suggestions in this chat. One day, I guess I'm gonna join in 3 of your chats. Are you listening? Okay. Hello? Hello?
Sharif? Can you hear Sharif?
Hello? Hello?
Can you hear me?
Yeah.
Yes.
I can't hear you.
Can you take your screen share out? Okay.
I'm sorry, I can't hear audio.
Can you hear now, Sharif?
Rose, can you hear me?
Yes, I
I'm
can
listening.
hear you.
Are
They
you
are
listening?
asking you if you can read in the chat the questions.
I guess two pathologists ask you about I guess this also for others, how we can join in a group or
I don't know what happened to the audio. You can hear me? I can't hear them.
Are you listening? Are you hearing me?
Yes.
We can hear you, Sharif.
No, I'm here.
I can bring my computer.
So we go to your.
Só um momento, Sérgio. A Thaís está ajudando ele lá no laboratório.
Ok.
Sérgio, minha sugestão é que, se alguém quiser fazer perguntas e ele puder responder, é melhor do que ler o
Exato. Ok. Então, um aviso, aqueles que têm, eu acho que Camila, Washington,
Conseguem me ouvir?
o doutor Barral também não fez pergunta, mas a doutora
Sérgio?
Marilda, oi, pode falar?
Você consegue me ouvir? Eu tô com o xerife aqui.
Sim.
O áudio dele, ele não está conseguindo ouvir vocês, mas a gente ouve ele.
É certo.
Então,
uma pergunta, é Rose que está falando? É, né?
É a Thaís. Eu sou brasileira, mas eu tô aqui no...
Ô, Thaís, é o seguinte, uma pergunta que está aqui presente no chat, né? é que como nós poderíamos desenvolver uma rede de patologistas, e eu acho que mais específica aqui de Salvador ou do Brasil, via Fiocruz, com CDC, para fazer uma vigilância mais continuada. Temos oportunidade disso?
O xerife está escutando. Se você quiser falar, ele pode responder também.
Dr. Zach, I guess there are many questions, and I join all about one collaboration or building a laboratory of vigilance in Brazil or worldwide to collaborate with CDC, or how we can strengthen our pathologist force to investigate. As you know, we have Zika virus, chikungunya, leptospirosis, leishmaniasis, all in now SARS-CoV. So we would like to hear about it.
Yeah, I mean, we certainly, collaboration is the main thing. And I see Dr. Freitas, I see Venancio on, and Rose is on. So we have currently several colleagues from Brazil here, and we're welcome. We offer rotations. So if any residents or fellows or even professors would like to visit, as long as have the funding, and we try to, so we can come and learn a lot about these. We have digital files, we have slides, so it's most visitors, let's say the majority, love it when they come here because they see a lot of things that are really in one place. So in terms of collaborations, I would say the best example is I started collaborating with Venancio, and then I've visited Brazil, probably 12, 15 times since I first visited, and I love, to work in Brazil. It's my favorite place to travel, but this is not about me. It's how we can better maybe share some antibodies. We try to publish papers with commercial antibodies. You can't have everything, but it depends on priorities. And I don't know if that answers the question.
Okay, that's okay. Anybody wants to make a question now? Directly by phone?
May I?
Sure. Go ahead.
Thanks, Freitas. Thanks, Sergio, everybody. Sherif, it's always a great pleasure listening to you. Always fantastic technical approach. Your slides are always superb, but mostly your person, your presence everywhere, and your availability along these decades must be always remembered. The point that everybody is raising is old, but brand new again. We have been trying to do a network, but the point is that we must continuously insist with our authorities. They must see the pathologists. This kind of meeting, this presentation of you helps a lot, but we must persevere. We must go ahead, and all of us here must be together applying and convincing people. In the beginning of the pandemics, we were called heroes, but now they do not remember us anymore. So we must come again and again. And this kind of meeting is very important for it. And thank all of you, especially Sherif.
Thank you, Venancio. That's very kind of you. I believe in a global village. We're all in it together, and we have to convince politicians and always go after money to support these. It's not easy, and unless you get buy-in by the hierarchy in terms of support financially, fellowships, travel, attending meetings, and collaborations in terms of actually exchange, between, it won't happen. And it goes in cycles, and but trust me, we even here at the CDC, we this affects us too. But nowadays things have changed. I guess with COVID, I mean, I can't imagine how many getting older. Now I wouldn't be able to travel like I used to. And it's there's some silver lining in all this, at least for me, in terms of just sharing with others and being able to present and talk with all my colleagues. But thank you, Venancio. And thank you, Sergio, and hi, Luis, Dr. Freitas.
I guess, Dr. Zaki, wait a minute. Look, Mittermeier, you want to make a question? Appears there.
No, I just want to congratulate Professor Zaki. We already have a collaboration between Fiocruz and CDC. Actually, my lab has a very close collaboration to do bacterial work. What you need to have is to find a specific project and to establish a collaboration with Professor Zaki. I want just to add a history that was very important in honor to Professor Zilton Andrade. In the middle 19, had a case of suspicion of yellow fever in the Cotomaya Hospital. And that time they tried to cover, not to come to the attention of the media. And Professor Zilton was invited to do the autopsy. He went during the night, and because he was interested to do an autopsy of a case of yellow fever. When he did the autopsy, it wasn't yellow fever. Everybody was thinking that it was yellow fever because the guy had a yellow skin, had jaundice. When Dr. Zilton did the autopsy, the case was leptospirosis. This shows how important it is to do autopsy. And unfortunately, we are not doing autopsy in the amount that we really need to help the public health, to help the vigilance, as Professor Zaki pointed. Again, congratulate Professor Zaki. It was really a very important talk connected clinical molecular epidemiology and pathology. Thank you.
Thank you, Dr. Mittermeier. Yes, autopsy decline is, and not the fear of autopsy, the numbers is disappointing, but what is coming along, and I didn't talk about it, and you have it in Brazil, and is the minimally invasive issue. Now, it's not as good as an autopsy, but for certain diseases, it will help. So like lepto, if you have and that's where what are they called? Were actually first used in Brazil. The old liver, what is it called?
Viscerotomy.
Viscerotomy, basically, yeah. I mean, that's the original needle biopsy. So, and actually, a couple of years, we had actually some viscerotomes made in Brazil, and we brought them, here and used them very early on. So, a very powerful tool, and we have to be innovative as pathologists. So if we can't do it, again, the viscerotome is a very good way, or more recently, needle biopsy. Obviously, as pathologists, we want to see more. So
before ending this section, I really would like to thank Dr. Zaki for his very comprehensive presentation. And I would like to say that for us pathologists, there is no doubt of our importance in situations like that and the role of the pathologist in moments like this. And I think that this is the moment to convince WHO to induce the creation and to support laboratories like the CDC of Atlanta in different parts of the world. And because this is very important in situations like this that we are facing now. Once again, I would like to thank you very much and say, Sharif, that I remember 2003 when you were in Brazil in the Congress in Curitiba, and your paper come out in the New England Journal of Medicine showing for the first time that coronavirus was responsible for SARS-CoV-1 and showing the importance of the pathologists in situations like that. So thank you very much.
Thank you, Luis. Thank you.
Thank you, Dr. Saki. We hope we'll see more again in this strange hour collaboration. We thank you very much in name of the Conferences Clínico Patológicas, your time spending in this conference. Thank you very much. Now I'm going to start Portuguese again.
Actually, I'm back.
I'm without mask because I'm alone, but I should use yours.
I'm with a mask because here's Thais.
Oh, hello. She's there. Thank you. Obrigado por nos ajudar aí.
Imagina, prazer.
Nós veremos logo. Nós veremos logo. Deixa passar na situação que está muito difícil. We are in a very hard time about SARS in Brazil also. Está increasing a lot. Everything. I guess we are in second wave now. Second wave.
Yes.
Thank you again. See you.
Thank you. Bye.
Bye. Então, eu aviso a todos que nós temos agora 4, eu coloquei no chat, vocês podem clicar e entrar em cada sala. Vamos dar 5 minutos e as salas vão começar a se abrir. Então, teremos 4 salas, uma sala de Ciências da Computação, uma sala de Hepatologia, uma sala para a Dermatopatologia e uma sala para Nefrologia. Os links estão aí. E cada sala vai ter um coordenador. Então, o programa completo está na nossa página, mas eu vou...
Yeah, but at the end,
A parte de dermatopatologia continua nesta sala. Aqueles que querem ficar na dermatopatologia, nós temos o primeiro convidado que entra daqui a pouco, do Dr. Walmar Roncalli, da USP, que vai nos falar sobre as patologias virais da pele. Depois nós teremos o Dr. Tiago Gionon, que vai apresentar a patologia de doenças virais. E assim em frente, até ao meio-dia. Depois da tarde, voltamos com Luciana, Rose Clay, Rose Celes e o Dr. Edgar.